Most fetal aortic stenosis is caused by congenital dysplasia of the aortic valve, or it can be due to bicuspid valve, or a part of the spectrum of the left-sided obstructive heart lesions. 10 to 20% of the cases are associated with genetic or chromosomal abnormality, particularly Turner's, Noonan's, and Williams. There is also a recognized familial predisposition with variants in genes such as NOTCH1 implicated in abnormal aortic valve development. When there is failure of remodeling, the valve leaflets becomes dysplastic, can be tricuspid with a fused thick commissures, or bicuspid or unicuspid or non-commissurate. The underlying pathology begins with the dysplastic.
Dr. Preeta, I may interrupt you. There is a request to switch on your video from Dr. Selvarani.
I'll try, sir.
Yeah, because they want to see you speaking.
Yes, sir. That will be very nice.
Yes, please. It's okay? Yes, it's you're very dark. You can switch on some light.
It's switched on, sir, actually.
Yes, it's very looking very dark. Okay, anyhow, proceed.
Okay, sir. The underlying pathology begins with a dysplastic stenotic valve that progressively thickens and becomes fused, leading to worsening obstruction of the left ventricular outflow. As the stenosis progresses, the left ventricle is exposed to increasing pressure overload, resulting in reduced ventricular compliance and impaired filling. The persistent afterload eventually causes endomyocardial fibroelastosis and LV dysfunction. In mild fetal aortic stenosis, the narrowing is limited to the aortic valve, the preserved LV size, and the function. The key ultrasound clue is the post-stenotic dilatation of the ascending aorta caused by high-velocity turbulent jet across the stenotic valve. Recognition of the subtle finding is important as serial follow-up is required to detect the progression to more severe disease. Here is a patient who was a second gravida presented for the routine anomaly scan. The initial suspicion arose due to the post-stenotic dilatation of the ascending aorta, and it showed a narrow turbulent jet across the stenotic aortic valve with a peak systolic velocity of around 180 centimeters per second. On short axis view, only two functional cusps were visualized with an eccentric coaptation point, suggesting possibility of bicuspid aortic valve with aortic stenosis. In the same patient, we also noticed focal narrowing at the isthmic region, suggesting prenatal suspicion of coarctation of aorta. The coexistence of multiple left-sided obstructive lesions raising the possibility of an incomplete Schoen's complex. I leave this intriguing aspect to our esteemed moderators who can further enlighten us on the diagnostic criteria and clinical distinction between the incomplete and complete Schoen's complex. In critical aortic stenosis, the left ventricle acting against the stenotic aortic valve becomes dilated and hyperechoic with echogenic wall and poor contractility despite its enlarged size, causing obstruction to the left ventricular outflow. The diagnosis is made by the abnormal four-chamber view where the LV is dilated, akinetic, and echogenic as a sign of endomyocardial fibroelastosis. The apex is formed by the dilated left ventricle. The mitral valve shows a limited or no excursion. The left atrium can be small or may be dilated in cases of severe mitral regurgitation. The LVOT view shows narrow aortic root with reduced movement and thick valve leaflets. The post-stenotic dilatation of the ascending aorta referred as aortic flaring. This is a case of second gravida with a previous healthy child presented for 30-week growth scan. The fetus had a globular akinetic echogenic wall of the left ventricle, and the foramen ovale flap was seen paradoxically bowing towards the right atrium, and with only minimal excursion of the mitral valve leaflets. There is only a trickle of transmitral flow with a hollow systolic mitral regurgitation. In LVOT view, the aortic valve is seen persistently in systole and diastole, and there was a narrow turbulent jet across the aortic valve with a peak systolic velocity of more than 200 centimeters per second. In the short axis view, the aortic valve was looking thick and dysplastic. Overall, the findings were suggestive of critical fetal aortic stenosis. color Doppler in four-chamber view, there can be reduced or minimal filling of left ventricle. There can be inversion of the interatrial shunt, left to right shunting at the level of the foramen ovale, and mitral regurgitation. The spectral Doppler of the mitral valves show abnormal monophasic mitral flow with short diastolic filling. In LVOT, there will be antegrade, often turbulent brief flow across the severely stenotic aortic valve. The peak systolic velocities will be high, more than 200 centimeter per second, but may be reduced. On 3-vessel trachea view, there can be a retrograde ductus-dependent aortic filling. And this was another case of 23-week priming, came for anomaly scan, situs solitus with levocardia. On four-chamber view, we can see the globular akinetic left ventricular wall with increased echogenicity, indicative of EMF. And here we can see the dilatation of the left atrium and arching of the foramen ovale flap towards the right atrium. And we can, in this video clip, we can see the very minimal excursion of the mitral valve leaflets. In LVOT view, we can see the stenotic thickened aortic valve with markedly restricted excursion of the leaflets. On color Doppler, there was turbulent antegrade flow across the aortic valve. And despite severe aortic stenosis, the peak systolic velocity was only 70 centimeter per second, likely reflecting ongoing LV dysfunction. On color Doppler, it shows adequate trans-tricuspid flow and only minimal transmitral flow, and we can see the mitral regurgitation during the systole. The ascending aorta and the transverse aortic arch was smaller in size and shows a reversal of flow from the ductus. There was also reversal of shunt across the foramen ovale with a bidirectional flow in the pulmonary veins. In 20% of the cases, there are associated cardiac anomalies such as coarctation of aorta, ventricular septal defect, and patent ductus arteriosus. When there is aortic stenosis with narrow mitral valve and coarctation of aorta, we should suspect Schoen's complex. Aortic stenosis may progress into frank hypoplastic left heart syndrome and amnio for Williams-Buren syndrome, and extracardiac anomalies are rare. If positive, we have to rule out Turner's. And this is the procedure. Early diagnosis not only identifies the lesion, but also creates an opportunity.
I think you can skip these slides so that
Okay, sir.
Dr. Shweta will enlighten
Okay,
more on this. Yes. Okay. Yes.
Plus 9053.
Not all fetuses with critical aortic stenosis are candidates for fetal intervention. The ideal candidate is severe aortic stenosis with an evolving hypoplastic left heart syndrome, where left ventricular growth and function are still potentially salvageable. The selection is based on the combination of anatomic and hemodynamic criteria. Includes aortic valve Z-score between -2 and -4, the LV length Z-score more than -2, mitral valve annulus Z-score of more than or equal to -3, monophasic mitral inflow, mitral regurgitant jet gradient of at least 15 mm mercury or aortic stenosis gradient of at least 10 mm mercury. The ideal window to perform is between 22 to 28 weeks of gestation. And this international registry study evaluated 108 fetal aortic valvuloplasty procedures, and the technical success was achieved in about 83% of the cases. But nearly half experienced procedural complications, most commonly fetal bradycardia and pericardial effusion. Multiple cardiac punctures significantly increased the mortality and the complications. The study highlights the need to carefully balance the timing and the procedural safety. Abnormal endomyocardial fibroelastosis and decrease in the peak systolic velocity on serial follow-ups, abnormal monophasic mitral inflow with reversal of flow in the pulmonary veins at end diastole. These are the markers for the functional deterioration to hypoplastic left heart syndrome. The three important differential diagnoses should be considered. First, the hypoplastic left heart syndrome, where the left ventricle never reaches the apex. Second, the coarctation of aorta, characterized by ventricular disproportion with the right ventricle larger than the left, narrow aortic isthmus, and shelf or arch hypoplasia with a normal aortic valve. Third is the dilated cardiomyopathy. Mitral regurgitation may be present. However, the structural and anatomy of the heart is normal. This flowchart outlines the practical approach of how to prenatally assess the fetal aortic stenosis. The suspicion arises when there is post-valvular dilatation of the ascending aorta or thickened aortic valve. The color Doppler is then used to identify the turbulent flow across the aortic valve. If no turbulence is present, no significant stenosis. If turbulence is detected, measure the peak systolic velocity. And if it is less than 100 centimeter per second, suggest no significant obstruction. If it is between 100 and 200 centimeter per second, that is consistent with mild aortic stenosis. If it is more than 200 centimeter per second, we have to check for aortic and mitral regurgitation. And if it's present, that identifies severe disease. Postnatal management begins with the stabilization of the newborn and prostaglandin E1 infusion to keep the ductus open. The first line definitive treatment is by balloon aortic valvuloplasty, if failed, surgical valvotomy. In cases of restrictive foramen ovale, atrial septostomy to relieve the left atrial hypertension. A brief note on bicuspid aortic valve. The bicuspid aortic valve occurs in about 0.5 to 2% of the population. That means statistically, if there are 100 people in this meeting, 1 or 2 of us may have a bicuspid aortic valve without even knowing it. And it can be frequently associated with aortic stenosis and coarctation of aorta. It may be a true 2 valve leaflets or a result of 3 leaflets with a fusion of 2 commissures. It can have a familial autosomal dominant inheritance pattern with notch 1 mutation. The prenatal diagnosis can be made with mild thickening and echogenicity of the aortic valve, 2 functional cusp with fish mouth opening during systole, and the coarctation point is the central point where the 3 cusps come together when the valve is closed, producing a Mercedes appearance. In bicuspid aortic valve, the coarctation line is often eccentric and rather than central because there are only 2 functional leaflets. This was a case of primary, came for the growth scan at 30 weeks. The LVOT showed the post-stenotic dilatation of the ascending aorta. We can see the turbulent aortic forward flow with the peak systolic velocity of around 180 centimeter per second. The short axis view will show the eccentric and thickened fuse valve leaflets, which are suggestive of bicuspid aortic valve with fused cusp and mild aortic stenosis. This was another case of primary at 30 weeks gestation, and the LVOT view showed the post-stenotic dilatation of the ascending aorta. There was a turbulent forward aortic flow, and on peak systolic velocity was around 150 centimeter per second. The short axis view showed the thickened and doming of the cusp of bicuspid aortic valve. On postnatal echo, it was proven to be a bicuspid aortic valve with mild to moderate aortic stenosis. We'll now move on to hypoplastic left heart syndrome, the most severe manifestation of left-sided obstructive heart disease. The hypoplastic left heart syndrome is a spectrum of congenital cardiac malformations characterized by the severe underdevelopment of the left-sided structures, left ventricle and left ventricular outflow tract, resulting in obstruction to the systemic cardiac output. The great arteries are normally aligned and there is no common atrioventricular junction. The hallmark features will include a hypoplastic ventricle, mitral stenosis or atresia, aortic stenosis or atresia, and hypoplastic ascending aorta and aortic arch. Consequently, the right ventricle becomes a systemic ventricle forming the cardiac apex. There are 2 forms, one is major and the minor form. In major form, there will be mitral and aortic atresia, no transmitral flow, severely small or almost non-existent left ventricle. In minor form, there will be high aortic atresia and hypoplastic but patent mitral valve, hyperechoic globular hypokinetic left ventricle with mitral regurgitation. Hypoplastic left heart syndrome accounts for about 2 to 4% of the congenital heart disease, but is responsible for nearly a quarter of neonatal cardiac deaths. It is commonly associated with bicuspid aortic valve and genetic conditions such as Turner's, Holt-Oram syndrome, trisomy 18, and with an increased recurrence risk in first-degree relatives. This was a primary gravida who was referred for a first trimester MT scan at 11 weeks. The cardiac axis appeared abnormal and the left-sided cardiac chambers appeared disproportionately small. There was a predominant right ventricular inflow and only a minimal filling of the left ventricle. These findings raised an early suspicion of left heart hypoplasia. The fetus also had a markedly increased nuchal translucency. The 3-vessel and the 3-vessel trachea views were unremarkable, and the ductus venosus showed A-wave reversal. There was also bilateral distended jugular lymphatic sacs, left-sided pleural effusion, and generalized skin edema, consistent with hydrops likely due to cardiac cause. Given the markedly increased NT and cardiac anomaly, an underlying chromosomal abnormality, particularly Turner's, was strongly suspected. The key second trimester findings of HLHS include a small or absent left ventricle, endocardial fibroelastosis, hypoplastic left atrium, a restricted mitral valve motion, and the rocking interventricular septum, the foramen ovale flap, paradoxical into the right atrium. The right ventricle forms the cardiac apex. On 3-vessel view and 3-vessel trachea view, there can be small ascending aorta, pulmonary artery larger than the aorta, a markedly narrow or non-visualized transverse aortic arch. This was a second gravida referred for an anomaly scan and the fetal echo at 25 weeks of gestation. The examination revealed markedly hypoplastic left-sided cardiac chambers with a thick echogenic left ventricular wall. The cardiac apex is predominantly found by the right ventricle. On 3-vessel view, there was a non-visualized transverse aortic arch, and on color Doppler, there was virtually no perfusion of the left ventricle. The aortic arch was seen filling only with a color Doppler retrogradely via the ductus. These findings were consistent with hypoplastic left heart syndrome. On LVOT imaging, the HLHS is characterized by hypoplastic ascending aorta, narrowed outflow tract, and color Doppler shows absent or markedly reduced transmitral inflow, which is the most important feature, mitral regurgitation, minimal antegrade aortic flow, and retrograde ductal filling of the transverse arch. Left to right shunting across the foramen ovale. So another case of a primary gravida presented for the growth scan, the fetus had a hypoplastic left ventricle, the apex was formed by the right ventricle, and the color Doppler demonstrated no transmitral inflow, and with the pulmonary venous return diverted across the foramen ovale into the right atrium. The ascending aorta was small and retrogradely filling via the ductus. The pulmonary venous Doppler showed the reversal of A wave. These findings were consistent with hypoplastic left heart syndrome. The left to right flow across the foramen ovale in hypoplastic left heart syndrome is due to the hypertensive left atrium. When there is wide foramen ovale, it facilitates the pulmonary venous return into the right atrium. When there is restrictive foramen ovale, it prevents the blood from shunting to the right side, restricts the pulmonary venous return, and forcing it back to the lungs. Causing pulmonary congestion, eventually heart failure and hydrops. This is the pathophysiologic reason for the pronounced reversal of the A wave in the pulmonary veins. This image shows the normal pulmonary veins with its typical pulsatile flow. The S wave is seen during the ventricular systole and D wave during early ventricular diastole, and the A wave that is a nadir at the end of a diastole. The pulmonary venous Doppler is an important marker for hypoplastic left heart syndrome. The end diastolic reversal of the A wave reflects the increasing left atrial pressure secondary to restrictive foramen ovale. The degree of reversal parallels the severity of restriction, ranging from mild reversal to marked A wave reversal, with the most severe form showing a brief to and fro pattern in the pulmonary veins, as demonstrated in our case. The restrictive foramen ovale is characterized by thickening and bowing of the atrial septum towards the right atrium. There will be narrow, turbulent left to right flow with a high velocity jet across the foramen ovale with a peak systolic velocity of more than 40 to 60 centimeter per second and with a foramen ovale diameter of less than 2 mm. In progressive cases, there will be minimal or absent shunting in severe cases. There will be abnormal pulmonary venous Doppler with jetting or biphasic flow. In 15% of the cases, it is associated with chromosomal abnormalities. The overall prognosis is poor with high morbidity and mortality. Since it is a duct-dependent systemic circulation, it requires PG1, prostaglandin E1 infusion. In restrictive atrial septum, we need to do atrial septostomy. If there is an extremely hypoplastic thread-like ascending aorta, it may preclude surgical repair. What about this slide, sir? The management of hypoplastic left heart
I
syndrome.
think these are animations.
Yes.
Since you told already
Okay,
the
sir.
basic pathophysiology, these animations from websites you can avoid, I think.
Okay,
Yes.
sir.
Okay.
Next, we'll move on to the coarctation of aorta. The congenital narrowing of the aortic arch most commonly occurs at the aortic isthmus between the left subclavian artery and the ductus arteriosus, and the spectrum ranges from the discrete segmental narrowing to the diffuse hypoplasia of the whole transverse arch. It can be simple if it is isolated, and it can be complex when it is associated with other intracardiac anomalies. The two major theories involved in the development of the coarctation of aorta is that hemodynamic theory, which says that the reduced fetal blood flow leads to the underdevelopment of the aortic arch, resulting in coarctation. According to the Squadike hypothesis, the ectopic tissue of the ductus muscle will extend into the adjacent aortic wall, and following the ductal closure after birth, the contraction of this tissue leads to the narrowing of the aortic isthmus, predisposing to coarctation. It accounts for about 5% of the congenital heart disease, and it is frequently associated with cardiac, extracardiac, and chromosomal abnormalities, especially Turner's, highlighting the importance of the comprehensive fetal evaluation. The indirect signs include the right ventricular dominance with an RV to LV ratio of more than 1.6, and the pulmonary artery is larger than the ascending aorta, showing a great vessel disproportion in the 3-vessel view. Can also be associated with the persistent left superior vena cava draining into the dilated coronary sinus. The ventricular and great vessel disproportion are key indirect markers of fetal coarctation, while these findings are less specific in the 3rd trimester because of the physiological right ventricular dominance, and they are highly predictive of coarctation when it is identified before 28 weeks of gestation. The direct signs include the small transverse arch, small aortic isthmus, and the ductal arch that is disproportionately larger than the aortic arch. On sagittal aortic arch view, the isthmus shows narrowing, there can be tubular hypoplasia, and tapering of the aortic arch upwards, and the characteristic posterior shelf sign. This was a primea gravida who presented for fetal echo at 26 weeks. The 4th chamber view demonstrated the chamber discrepancy with the right ventricular dominance, and in the 3-vessel view, we can see the great vessel disproportion and a narrow aortic isthmus alongside a relatively larger ductal arch. On the sagittal view of the aortic arch, we can also notice the tubular hypoplasia of the transverse arch. And this was a 2nd gravida who presented for routine anomaly scan. The 4th chamber view shows the ventricular size discrepancy with the smaller left ventricle. And on 3-vessel view, there was an additional vessel known as representing persistent left superior vena cava draining into the dilated coronary sinus. On evaluation further with the sagittal aortic arch, the shelf sign was seen at the level of the isthmus, showing focal narrowing, which was better delineated with power Doppler. For those of us who like measuring everything, these are the numbers we rely on. The most important are the RV-LV ratio of more than 1.3, the ascending aorta Z-score and transverse arch Z-scores of less than -2, and the pulmonary artery to aorta ratio of more than 1.6, the isthmus to ductal ratio of less than 0.74. The Wang and colleagues proposed a clinical prediction model based on the objective measurements of the fetal aortic arch. The distal transverse arch diameter is measured between the left common carotid and left subclavian arteries. The Z-score of less than or equal to 0.37 is suggestive of significant arch hypoplasia. Two geometric angles are also assessed: the ascending aorta to descending aortic angle that is formed between the internal borders of the ascending aorta and the descending aorta, with a cutoff of greater than 30 to 32 degrees. Transverse descending aortic angle is between the transverse arch and the descending aorta, which is greater than 96 degrees, supports the diagnosis of coarctation. When the primary Z-scores are borderline, the secondary morphologic markers improve the diagnosis of coarctation. The increased distance of more than 3.5 mm reflects the stretching and elongation of the transverse aortic arch. In addition, the left subclavian artery is displaced distally and seen arising close to the ductal insertion. Now, this was a 2nd gravida referred at 23 weeks of gestation with the history of previous IUD. The 4th chamber view revealed a significant ventricular disproportion with the right ventricular dominance. With the quantitative assessment showed markedly reduced mitral valve and left ventricular Z-scores. On the 3-vessel view, we can see the great vessel disproportion. The sagittal arch demonstrated the hypoplastic transverse aortic arch with increased distance between the left common carotid and left subclavian artery. There was also a suspicion of polydactyly and micropenis. The pregnancy was subsequently terminated, and the postnatal examination confirmed the findings of micropenis and polydactyly. The association of obstructive cardiac anomaly with these extracardiac findings raised the possibility of an underlying genetic etiology, particularly Smith-Lemli-Opitz syndrome, as reported in the literature. However, despite all these diagnostic pointers, the prenatal suspicion of coarctation is like watching a movie trailer. It teases the possibility of only coarctation, but we can't give away the ending. So the final verdict often comes only after birth, because the fetal assessment has a high false positive rate. Once the diagnosis is confirmed, the prognosis of coarctation depends on the severity of obstruction, presence of associated cardiac, extracardiac, and chromosomal abnormalities. With timely diagnosis and surgical repair, the isolated coarctation has an excellent prognosis of more than 95%. To bring everything together, we'll conclude with the interrupted aortic arch, where there will be a complete structural discontinuity between the ascending and the descending aorta. It is classified into 3 types by Celoria and Patton based on the location of the interruption in the aortic arch. In type A, the interruption occurs distal to the left subclavian artery. Type B is the most common type, and it occurs between the left common carotid and the left subclavian artery. It is associated with a large malaligned ventricular septal defect and has a strong association with 22q11.2 microdeletion syndrome. In type C, it is between the innominate artery and the left common carotid artery. We'll now focus on the key sonographic findings that distinguishes interrupted aortic arch from the coarctation of the aorta. This is a case of the interrupted aortic arch where the 3-vessel and the trachea view demonstrates a loss of normal continuity between the aortic and the ductal arches, the trachea lying in close proximity to the pulmonary artery. The long axis of the sagittal aortic arch view shows a straight rather than the normal candy cane configuration of the aortic arch, with only 2 branches are visualized, producing a typical V sign. This is another case referred at 23-week anomaly scan. The 3-vessel and trachea view, the trachea appeared immediately adjacent to the pulmonary artery with the loss of the normal V-shaped confluence of the aortic and the ductal arches, the characteristic feature of the interrupted aortic arch. There was also a malaligned ventricular septal defect. And in this video clip, we can see the characteristic straight course of the ascending aorta without its continuity into the distal aortic arch, confirming the diagnosis of interrupted aortic arch. With that, I would like to hand over to our eminent moderators who will further elaborate on the current treatment strategies and evolving management of these challenging lesions. Thank you.
It's a great presentation indeed. You covered almost all images, diagnostic clues, pictures of the critical aortic stenosis and coarctation of aorta, as well as the interrupted aortic arch. First, we will take questions if there are any questions. Right now, there are no questions.
Right now, there are no questions, sir.
Right now, there are no questions.
Yes.
So, to summarize your points, people who are listening, I think if you come across in the mid-trimester, the aortic stenosis, whatever the findings, there's a criteria which probably next speaker is going to tell the scoring system whether it is suitable for the aortic valve dilatation or impending HLHS, which is going to progress to HLHS, is possible. Whereas 30 weeks and all, what you have shown cases, it's a good idea to see the postnatal outcomes, whether they had undergone any balloon dilatations after birth, how they behaved. We all will get more idea. Maybe you can share during your discussion points. Pertaining to the pulmonary venous Doppler, I think it's a very great Doppler. What you have shown is to and fro, but we call it as the A-wave reversal, which is significantly higher, and A-wave duration also important. If the A-wave duration more than 18 milliseconds or 20 milliseconds, but definitely more than 20 milliseconds, it suggests that there is a restrictive physiology. Most of the patients, they develop ventricular dysfunction and mitral regurgitation, and it's technically very difficult to align in the narrow jet to get that criteria for 200. So our practical approach is, if there is a ventricular dysfunction, mitral regurgitation, even if you don't get proper velocities, incomplete velocities or very sparse, insignificant Dopplers you will get, that also suggests contributes it's a critical aortic stenosis, because you have already the aortic arch reversal is there. When you have a reversal in the aortic arch, it is possible. Sometimes you will see the ascending aortic dilatation as an aortopathy. That gives you again information that it is a bicuspid valve. But sometimes it may not be seen, some of the monocuspid valves and also horizontally oriented bicuspid valves. But your pictures of bicuspid valves is amazingly great. It's not that easy to get the short axis view of the aortic valve. Only in experienced hands you can produce that. I think those are amazing pictures which you have shown that. Maybe I'll ask Dr. Shanti to give some comments. I would definitely like to participate in the audience discussion at this point of time.
Yes, sir.
Thanks, Dr. Nageshwar. Divya, that was a very nice, exhaustive presentation covering all the possible lesions on the left side. I agree with Dr. Nageshwar's valid, points, especially pulmonary venous Doppler and how you look at the actual, A wave. There are a few things for the overall general audience. I want to share a few things, highlighting whatever you've already said, because I want them to remember this. Because when I see referrals coming, from either as HLHs or suspected LVOT lesion or as choriodilated cardiomyopathy. So in fetal life, because the commonest differential people keep for this in the beginning of the imaging is whether it's cardiomyopathy or fetal heart failure, looking at this globular LV. So in fetal life, when it's cardiomyopathy, most of the time it is dominant RV or biventricular rather than isolated LV, because we know RV is the dominant ventricle in fetal life. So when RV gets affected, both share the burden. So more often you get a biventricular cardiac dysfunction or dominant RV dysfunction. Getting an isolated LV dysfunction with a distended LV, the first thing you have to, anybody who's imaging has to rule out is a aortic stenosis. Because, and another thing which I again want to stress on is a primary imaging person, whether it could be an anomaly cardiac screening or a fetal echo, not to get deceived by the aortic valve annulus size or the aorta size, because aorta is going to look bigger. And if you don't pay attention to how the valve actually looks, and whether the valve opens and closes in systole and diastole in 2D image before you put your colors, that will again lead you towards the diagnosis, because often there could be some confusion on what this possible lesion is. That's one point which I want to stress on among the ones which you quoted. Another thing, just a word of caution, Divya, about the early trimester naming as HLHs. Some cases are because we know the tertiary centers and many are doing the very early echoes, or even during 12 to 13 weeks scans, or 16, 17, 18 weeks, because some cases are very, very typically the pure hypoplastic left heart. But sometimes the what we call as asymmetry or disproportionate ventricles the second trimester may look like HLHs in a early trimester. So I think people who are imaging early hearts have to play a cautious role and not to label everything as HLHs. I just want to quote this one example before we move on to the next talk. I had a mother who had lost first baby was stillborn, no cause. Second baby was diagnosed as HLHs in late trimester and delivered in some hospital where there was no facility available, and baby died within 3 days when the duct closed. She came for the third pregnancy early scan, and early scan someone has called at 12, 14 weeks as hypoplastic left heart. And so this family was very, very keen to continue, and they were very heartbroken when they heard that this one also has HLHs. And since they were waiting to continue and all that, we advised them to wait and review the heart. So 16 to 18 weeks, it was not a pure hypoplastic. All flows were okay, all valves are opening, and all the flows were normal. There was significant asymmetry and completely followed up, including genetic testing. And it was a single gene something without any major anomalies. The child is now going to second standard. And they
Right.
send me a photo whenever the child gets first prize in running competition. This is a real life story. So that is something which I really want all the early imaging people to be very cautious before you call a lesion, because not all the asymmetric chambers become hypoplastic left heart. Okay, thanks Divya, and I think I can wait to listen to Shweta.
Yes.
Now,
There
there is a
are few
question in
questions.
the chat box. Criteria for G scores for left and right heart obstructive disease. It's a very important question actually. The left heart G scores, if it goes more than minus 2.5, it's a dangerous. So the criteria is more than minus 2. That means minus 1.8, minus 1.5. So if it comes, it's a good case for the biventricular association. Whereas right heart, you can wait even till minus 3, because the right ventricle length sometimes in hypoplastic left heart syndrome, it's very difficult to assess. You go by the tricuspid annulus G scores or right ventricular diameter. So in right heart, the diameters are more important rather than length. That is, width is more important. Whereas in left heart, both width and length are very important. So right heart G scores, you can stretch a little bit more, but whereas a left ventricle, if you stretch, they may develop left heart hypoplasia. Okay. Sure, sir.
Yes, sir.
Any other?
We
So
take your input, sir.
pertaining to, sorry, you are talking?
No, thank you for your input, sir. I just
No,
wanted.
pertaining to the other interruption, I think dining fork sign, because the sagittal weave is very difficult in aortic arch interruptions, especially when you are dealing with type B and all. It's not possible because your duct arch will always obscure the image and you will be confused. So a semi-sagittal, semi-coronal plane will give wonderful view that your neck vessels will go like this in semi-coronal plane. So when you have a dinner fork sign, that gives you definite information. And your posterior malal and VST, you have shown that very nicely. The posterior malal and VST makes the first hemodynamic theory, where the LVOT will come down, the amount of blood which is going through the ascending aorta transverse arch will be significantly reduced. So that's why you have redistribution of flow to the right heart will be there. So in coarctation of aorta, because of the isthmus narrowing, which is supposed to give 8 to 10% of the blood to the descending aorta oxygenated, which is blocked, same amount of blood will be redistributed to the brain. So your cranial circulation, there are MRI studies by John Simpson group and Edgar Jedge group from Sick Children, Toronto. The amount of redistribution of blood to the brain is increased. So that if you calculate the SVC flows, the superior vena cava flow will be increased. So superior vena cava flow in fetal life will try to go directly to the right ventricle rather than through the foramina well back to the LA. So therefore, your right heart effectively is receiving from SVC additional 8 to 10%. So you will have absolute values of right heart dilatation will be there. So it is predominantly your SVC returns are high. That's why your right heart is dilated in coarctation. That is going to be very important point in the presence of multiple parameters like crowding of neck vessels, isthmal narrowing, isthmus to other diameter ratios, angulation. If you have even SVC flows, Dr. Shweta and myself, we are studying that SVC output in fetus will give, because several times we think coarctation may not be there postnatally. We may be sometimes giving you different prognosis to the family. Sometimes we feel that there is no coarctation. Coarctation will appear after 2 to 3 months after birth. Then they will first time will come to me. They will ask, is the fetal medicine specialist wrongly diagnosed? They ask. So we never ever, because that particular time you are not doing longitudinal scans. In left heart disorders, the key is you have to do longitudinal scans, very important when you are actually following the fetus. Thank you, sir.
Thank you, sir. Thank you for the input.
I just want to add on one thing, Dr. Nageshwar. That is because the recent, I think, bigger centers are reporting false positivity of up to 30% in a coarctation in antenatal, and even recently I saw 1 or 2 babies. We all should agree that there is a false positive thing, because mostly because we are not able to, in our countries like us, we are not able to do serial assessments. And one more clue which I use and I've learned from my training also, when you're in the even 3-vessel trachea view, because as doctor mentioned, the sagittal views or parasagittal views may not be easy or possible all the time. In the 3-vessel trachea view, if your transverse arch is significantly hypoplastic, it very small Z scores, but you're not seeing a flow reversal from ductus, then I will keep my first differential as interruption. Significantly hypoplastic arch, where I will anticipate a duct supplying the transverse arch. When I don't see the ductal reversal, then I would strongly suspect interruption. We have had few cases proven like that, because they are not connected in an interruption. Okay.
Okay.
Thank you.
So the Dr. Shweta can present now.
Yeah, now may I request Dr. Shweta Bakru to talk on fetal cardiac therapy in critical aortic stenosis.
Good evening, everybody, and I thank Dr. Manohar and the entire Fetal Medicine Society to give us the opportunity to present the fetal cardiac therapy, especially in case of aortic stenosis. And most of the imaging part has been very nicely covered with Dr. Divya, so I can directly go to the management part in case of left-sided obstructive lesions. So a little bit about, it has been greatly emphasized that how the longitudinal scans are so important in left-sided obstructive lesions. So a little bit about what changes actually in aortic stenosis. This is what we need to understand, then only the importance of the fetal cardiac interventions would follow. So it has been described long back, almost in 1990s itself, by John Simpson group, where they have selected 27 fetuses, and out of that only 2 underwent fetal life, the aortic valvulotomy, and they have found out that the 60% of them progressed to develop the hypoplasia of the growth of the left ventricle, and they required the single ventricle pathway. And they have mentioned in their studies that there was a failure to growth of the left ventricle, like it has been seen in this our case, that there was a critical aortic stenosis and where the family refused for fetal valvulotomy, and then finally it showed that the left ventricle was very small and the ascending aorta was very small here, and the left ventricle in transection view also showed that it failure to grow completely. So it is not unusual to see the development of fetal aortic stenosis, especially in early trimester, developing into the hypoplastic left heart. And what has been shown in this, that the growth of the left ventricle should happen longitudinally as the gestational age advances. But because there is a fixed outflow tract obstruction, the left ventricular dysfunction starts, and therefore there is a diastolic increased pressure, and due to poor contractility, which will cause left ventricular dilation, which might lead to mitral regurgitation, which would add the flow reversal in foramen ovale and would ultimately become the small left-sided cavity, and it is also added by the primary endomyocardial fibroelastosis. And it has been also added that the aortic valve growth and the mitral valve growth also gets hampered because of the flow theory. So there is a primary insult of aortic stenosis, and because of that, there is a secondary insult in the development of the left ventricle, mitral valve, and the aortic valve growth. And that would lead that we can see hemodynamically by retrograde flow and everything. So what we want to do in the fetal life is the lesion which start as a benign lesion, that is the simple aortic stenosis, which would lead to the altered flow and lead to the finally a very complex lesion, that is the hypoplastic left heart syndrome. So the hypothesis is, can we halt the process at the primary level itself, at the aortic stenosis level, so that the flow alteration can be stopped and we can allow the growth of the left ventricle by the by the normal flow, like how it would happen in the otherwise fetus, and thereby preventing the development of the hypoplastic left heart syndrome. So that is the primary hypothesis, and let's see how it happens. So aortic stenosis is a benign spectrum or a simple lesion of the aortic valve. It is not. It is not always like that. It can be a combination of lesion, which can be a primary pathology or can be a secondary pathology. So it can be an isolated aortic stenosis. It can be aortic stenosis with dysplastic MR, aortic stenosis with intact septum, with narrow LVOT, arch abnormality, AS with hypoplasia of LV, AS with abnormality of the primary abnormality of mitral valve leading to the hypoplasia of the mitral valve. So this is all the spectrum of aortic stenosis association is possible. And let's see that how many of them we can really treat by fetal cardiac intervention. So we have all understood that the picture which is looking like this, where the right ventricle is dilated, LV is like this, which is a button shape, not forming the apex, hardly contracting. And you can see that hardly there is a flow. And even if you open here the aortic valve, the pathological changes has been already happened and is not going to convert into the biventricular.
Shweta?
Shweta, there is some interruption in the audio.
Your network, you can switch off your video.
Hello?
Yes, your head. Now you can switch off your video. Your network bandwidth is low.
Okay, sir.
You can switch off your video so that you can seamlessly present.
So in case that there is a hypoplastic left heart syndrome, which is well established, the treatment pathway is Norwood therapy. And here the left ventricle is not useful in the biventricular pathway. And we use right ventricle as a systemic ventricle, and we create a very complex surgery, like the pulmonary artery will behave like connected to the aorta, which is hypoplastic. And then we have to give additional shunt from right ventricle to the pulmonary artery. And ultimately it goes like to the single ventricle pathway, and it has got very high mortality and very, very complex challenges are there, especially in early neonatal life. So what is the treatment then? So should all aortic stenosis go for the fetal therapy? Now look at this case. There is a left ventricle which is good size, and there is a normal foramen oval flow, and you can see that there is a flow acceleration across the aortic valve. And we can see here the LV size is good. The aortic velocity is reaching more than 300 meters per second. The mitral valve is normal. The LV is well formed. So this is not the case which needs actually the fetal aortic valvotomy, because not all anatomical lesion will have hemodynamic alteration. So the aim is where the hemodynamic alteration start, they are the candidates where probably we need to do the fetal cardiac procedure and then halt the hemodynamic process. So this case, what I have shown, had severe aortic stenosis, but left ventricle was always well preserved. The foramen oval flow was always well preserved. And therefore, we did not do any procedure, and this baby was delivered, and he underwent biventricular correction by just balloon aortic valvotomy, and that too after the birth. So which case then we should select? This is the biggest question. So case selection is very important. And as I said, it is not only the sizes of the ventricle, mitral valve size, aortic valve size, but to document that there is a hemodynamic alteration which is coming. So these are the fetuses which are going to benefit by the fetal cardiac procedure. So here LV length Z-score should be normal. Aortic Z-score we can accept more than -3.5. Mitral valve Z-score should be more than -2, and there should be a documented aortic stenosis. along with the flow reversal into the aortic arch and abnormality of the left ventricular function or abnormality of the mitral valve flows. So let's look at this case, that what happens here. So before assessing the case, we should remember that they are the two cases, they are the two patients, and we are going to give the fetal therapy, but the mother is innocent. So the procedure should be very safe to both the candidates, and all the safety measures should be taken before going ahead the procedure. So this is the technical and imaging things that we need to keep ready. We need to have the team of various caregivers, but the entire procedure is done under all aseptic precautions, probably in OR, under the ultrasonography. And we have to use there are various puncture needles, especially 18 gauge needles, which are available. There are no custom made catheters, balloon catheters for fetal procedure. The experience comes from the pediatric balloon catheters, and 3.5 or the coronary balloons are specially used for the valvotomy balloon catheter. And then the wire to cross, and then we have to keep ready few medicines for the fetus to give anesthesia, and in case of there is an emergency. The team member is very important here. Presence of pediatric cardiologist, the anesthetist, the obstetrician, nurse, fetal echo technician, and the cath lab nurse, who are going to give the proper comprehensive care to the fetus. So how the procedure happens, this is, as I said, it's ultrasonography guided. And as I said, it should be done under all aseptic precautions, and it is trans-abdominal, maternal abdomen, trans-uterine through amniotic fluid directly. It requires the puncturing of the aortic, the left ventricle, and thereafter entering into the stenotic valve, and then taking your balloon wire assembly and opening the valve is the aim of the therapy, and this is how the procedure has been executed. So let's see a few case examples how we have done this procedure. This is a 28-year-old science teacher, second gravida. This was our first case, 23-weeker. And as you know that there is here the four-chamber looks normal, the foramen ovale looks fine, the flow looks fine, but there was a stenotic flow across the aortic valve, and you can see that there is a slight stenotic flow across the mitral valve also. And this is the arch flow. We can see a turbulent flow coming across the arch, which has been propagated by the aortic valve, and there was increased velocity of the aortic valve. Now, at this stage, because there was no hemodynamic alteration, she was just monitored. And later on, we saw that there was EFE, which was setting in. There was left ventricular dysfunction, which was just setting in. These are the various parameters which are important to go ahead before taking the procedure. There was development of mitral regurgitation, and there was flow reversal across the arch of aorta. And also we found out that there was a flow reversal across the foramen ovale. Now you can see that the flow reversal is very well seen from LA to RA here, and the flow across the aortic valve is very, very stenotic. And left ventricular length has just started shrinking. So this is the case where if we don't do the procedure, would probably land up into the hypoplastic left heart eventually. So after proper informed consent, it was decided to go ahead with the procedure. And here, initially, the fetal anesthesia was given by fentanyl and atropine, fentanyl and vecuronium, and followed by the atropine and adrenaline was kept ready in case of emergency, and fetal general anesthesia was initiated after that. So here, the needle is coming across, you can see the uterine wall into the direct puncture into the left ventricle. And you can see that the needle has entered the left ventricle, which is just opposite the aortic valve. And then gradually the valve is crossed by the coronary wire and balloon assembly. And ultimately, we can see that the dilatation was performed under ultrasonography guidance. This is the wire which has come across the aortic valve, and then the aortic valve dilation was performed under the echocardiography guidance. Once the procedure is performed, we can see that the velocity has come down. There is a better flow. Earlier, there was much hesitant flow which was going across the mitral valve. Now it is a nice smoother flow which has gone across the mitral valve. The foramen oval shunting is RA to LA. We can see that the left ventricular function is better and the aortic valve flow is also much improved. So this was our first case of fetal aortic valvulotomy and has done very well. And this child is almost 10 years now and is leading a normal life. Now let's look at this second example. This was actually a twin pregnancy and the other twin was normal. The first twin, as you can see here, there is a severely dysfunctional left ventricle and there was mitral regurgitation, and this happened secondary to the aortic valve stenosis. Now, here the other twin is totally normal, so I can understand the questions like why we should do the fetal procedure, but the parents were very much keen into saving this baby as well. And because it is a DCTA twin, with discussion with obstetrician and the entire team and the JCC team, it was taken a decision that okay, the fetal procedure can be done in this twin. So after securing a proper fetal position where the heart should come much anteriorly, you can see the needle is entering into the left ventricle. And what happens just after the entering of the needle into the left ventricular cavity just collapses, and therefore the image quality would be substantially very low, and therefore we should make sure that the fetal position is very, very accurate before going ahead the procedure. Now you can see here the wire has crossed across the aortic valve. This thin structure is the wire across the aortic valve, and now you can see that the balloon is getting expanded across the aortic valve. Now what happens once you have dilated the balloon? We should see the aortic regurgitation. That would say that there is a improvement into the aortic valve flows, and it would determine the success of your procedure. But what happened to this baby later on? So this is how it is so important to have longitudinal scans and so important to understand the physiology. This baby, because of high LA pressure and there was mitral regurgitation, which lead to the diastolic dysfunction and the closure of the foramen oval. The foramen oval got restricted. There was presence of mitral regurgitation. You can see that E wave is taller than the A wave, and there was much taller A wave across the pulmonary vein, which suggests that there is a severely restrictive physiology of the left atrium and left ventricle, which would cause the intrauterine pulmonary edema. And when this baby was delivered, you can see that the foramen is closed and had very high LVEDP and had severe pH because of the restrictive physiology which persisted, and there was mitral regurgitation, as you can see here. And because of this abnormal restrictive physiology, this baby succumbed. So very important to understand physiology and prognosticate during fetal life these fetuses. Now let's see this third example. Again, there is a dysfunctional left ventricle which is very dilated here. There is a right heart also which is dilated, and this was due to the severely thickened aortic valve, you can see, which was bicuspid in nature, and this has led to the severe aortic stenosis, and there was mitral regurgitation which was moderate to severe, and there was already established severe left ventricular dysfunction. Now once you have this kind of case, you can see that the mitral regurgitation which is going across the foramen oval shunting left to right. Luckily the foramen oval was well preserved and pulmonary vein Doppler was good. And there was severe aortic stenosis. There was flow reversal which was seen in aortic valve, in the ascending aorta. Again, this is a case where if it is not treated, would have left ventricular dysfunction, progressive mitral regurgitation, may develop hydrops due to mitral regurgitation, and therefore the fetal aortic valvulotomy is warranted here. So initially we went ahead and we did with the needles that we had earlier, and we passed the coronary wire 3.5 balloon, and the procedure was successful. So as we know that we have punctured the heart, what would happen once you puncture the heart and you try to withdraw the needle? There is a very common chance of development of hemopericardium. There was severe bradycardia followed by tachycardia, and there was inadequate opening of the aortic valve here because there was some technical problem of aortic valve to balloon size mismatch. There should be adequate size because there are no shelf hardwares available for fetal procedure. You really need to customize it and see how you can best utilize in the fetal cases. So therefore, it is always challenging to arrange the hardware in these cases. Now, here is a situation where there is a hemodynamic collapse and the inadequately open the aortic valve. So we have to take a really bold decision and then go ahead with, you can see that there is a formation of pleural effusion also. So what we did is we went ahead with a bigger balloon and over the bigger needle, and we successfully dilated that aortic valve. Now the real danger was if we try to remove this balloon out, then there would be profound hemopericardium. We can drain that hemopericardium, but there would be a volume loss which fetus may not tolerate. So what should we do in this situation? So therefore, we decided to close that rent which has been created with the needle with a device. And therefore, as you can see in this case, that while removing the needle, it was the left ventricular entry point was closed with a small device, and there was very good flow across the aortic valve. The left ventricular function completely improved. And because we could dilate this with a bigger balloon, this baby did really well. You can see here the mitral regurgitation substantially reduced, and there was an adequate flow across foramen ovale, adequate flow across the aortic valve. And for 300, the aortic velocity just reduced to 140 now. We followed up this baby for future development of re-aortic stenosis or ventricular dysfunction, but this child did extremely well, was delivered normally on the term time, did not require any respiratory support. On X-ray, you can see that the device is in position. And after birth, you can see that the left ventricle is good size. There is no mitral regurgitation. Aortic valve flows are very, very adequate. There is no aortic regurgitation. And this baby did not require any aortic valvotomy till now because of the adequate flow across the aortic valve. And after delivery, there was only mild aortic stenosis. So this was a very gratifying result where the left ventricular size preserved, the left ventricular function improved, and this baby did really very well. So do all the cases of aortic stenosis would have this kind of wonderful outcome? And what are the other substrate which may not do adequately like how we have discussed? So this is one of the substrate which have really very poor outcome, and I would like to highlight here. So these are the cases of severe aortic stenosis, and they have dysplastic mitral valve and severe mitral regurgitation. This is one of the paper again published back in early 2000, and which showed that wherever there was severe mitral regurgitation and LA, which is hypertensive because of the mitral regurgitation, progressed to have the hydrops, and with or without procedure had succumbed. So 60 to 80% of them has got chance of either fetal IUD, intrauterine death, or after delivery, neonatal death. So these are probably the worst aortic stenosis candidates, and they may not do well even after the procedure. So what do we learn from the result from the international FCI registry? Is it always that success that we can anticipate? And does technical success transfer to the biventricular circulation? Our aim is to achieve a biventricular circulation. So in their entire series, you can see that the biventricular circulation was achieved only in 30 to 40% of the cases. But when they have analyzed the single center experience data, the success rate was up to 80%, and biventricular circulation was even achieved up to 70%. So why this different? So whenever there is a multi-center data which has been collected for fetal procedure, there is a steep learning curve in the selection of case. So a case selection, deep understanding of physiology, understanding the longitudinal follow-ups, changing with your fetal hemodynamics and associated co-lesions. These are the very important determining factor in your ultimate outcome for biventricular repair. So the experience center, which has pooled cases, a best selected case, may have a really good outcome, as we can see. I don't know from where this is coming, but so the potential complications can be the perioperative fetal demise, which can be up to 10%, early procedural death, which is 10 to 15%, fetal bradycardia, hemopericardium, which might be requiring drainage. So therefore, we should be very mindful in selecting the cases and offering this procedure for the fetuses. And we should have a thorough understanding of the physiology that this baby is well selected and is going to benefit from your fetal procedure. So this is all from for the fetal cardiac therapies. If the time permits, I can talk about the coarctation of aorta, or I can directly go to the conclusion slides as well. This is the few slides on coarctation, but I'll leave up to the moderators if I should present this or not.
I think we have
enough time.
Yeah, time, Shweta, you can complete.
You can complete it with the coarctation. Yes.
Okay. So as we have well discussed about the factors about picking up the coarctation of aorta in fetal life, among all factors, the dilatation of right heart remains the very important initial suspicion. Then there is a flow reversal of arch of aorta exists, flow reversal across foramen ovale. But one important parameters that should be taken into consideration is the isthmus size in the transverse arch, especially in the sagittal view. As you can see here, there's a crowding of neck vessel. The isthmus looks really very small here, and there is a clear-cut flow reversal is seen from the ductus arteriosus into the arch of aorta. So this is the baby who is going to present with coarctation of aorta and should be delivered close to the cardiac center, and the neonatal team should be ready to handle, especially prostaglandin should be kept ready, and we should avoid giving oxygen to these babies after birth. Now let's see what happened to this baby after birth. As you can see that the right heart looks little bit dilated, and when we did the arch view, there was just mild turbulence across the arch. So is coarctation there or not there? So we should not dispatch this baby saying that there is no coarctation of aorta, because presence of ductus arteriosus can really mask your coarctation of aorta. Now let's see what happened here. Once the ductus got closed, this baby got precipitated with severe coarctation of aorta. And as it was discussed earlier, they should be closely followed up even after the birth, and better to be keep in hospital, and the hemodynamic monitoring in the form of upper limb, lower limb blood pressure, and maybe daily echocardiography is required in highly suspected cases. Now, this case has done wonderful. The surgery was done on day 3 of life, and isolated coarctation of aorta requires usually a surgery from thoracotomy, and they have got very good outcome. Now, this is the another case who is 30 weeks, and as you can see that the right heart is dilated, left heart looks skinny. There is a mild flow reversal across the ascending aorta, and PA is dilated here. So is there coarct or there is no coarct? So let's see what happened to this baby. So this baby had no coarctation after birth, even after the ductal closure. So we should be very, very mindful to label all right heart dilatation as coarctation of aorta, especially in last trimester. Because in last trimester, there is a physiological dilation of the right atrium and right ventricle, and other causes of right heart dilation like restriction of foramen ovale, restriction of ductus arteriosus, the placental insufficiency, and other confounding factors should be considered before labeling as coarctation of aorta, because that is going to really increase the anxiety in the given family. So we should be little bit mindful and should have all the physiological assessment again before labeling as coarctation of aorta. So in conclusion, in utero intervention for selected cases, cardiac condition has got role and can change the natural history. The technical challenges are more and need to be developed the hardware. And I really thank you all. These are the few cases who have undergone the fetal cardiac procedure and have done well, and it is really gratifying in selected cases. So I thank you, everybody.
Thank you, Shweta. That is a fantastic session on intervention, highlighting on the selection criteria, how selection is very important overall, in addition to the echo parameters, overall looking at the outcome and a successful intervention story from your center with a lot of information. So I think there are some questions, and Dr. Nageshwar can.
Yeah, maybe you can stop sharing, I think, first, because everybody can have interaction. Can you please stop sharing your screen, Shweta?
Yes, sir.
Dr. Nageshwar has already answered a question. Do you want to expand on that?
I think the cost is we did not cost. It should be costing like any other balloon procedure around 1.5 to 2 lakhs, but we have a very peculiar aspect in our hospital where we want to do fetal cardiac procedures from 0 to 60,000 rupees. That means if patient can afford 60,000, we charge it. If patient can't afford, we will still do it, because a lot of patients, as soon as we tell the fetal procedure is required, they will tell that we will come tomorrow. Then we will be waiting for everything. Next day we will be waiting, and we will try to communicate them. Their phones will be switched off. Then after a couple of weeks later, we will come to know that maybe this we have been seeing that the actual procedures which will happen less than 5% of the patients. Therefore, cost should not be a barrier for this procedure. That's one. But the ethical question comes whether postnatally again you are going to have the great outcome. Is the fetal balloon valvulotomy the standalone procedure is going to be an issue. So fetal balloon procedure, we should tell that it is not a standalone procedure. 80% of the times you may have to do second procedure. So in some, what Dr. Shweta has shown, the balloon dilatation, balloon ruptured. She has shown one slide, actually did not speak on that. Balloon ruptured, then we could not remove the balloon properly. That's where left ventricular injury happened. And subsequently valve did not open to the size of what we expected, because we are supposed to use 4 millimeter balloon. So some of the participants mentioned that what the size of the balloon. Generally speaking, 4 millimeter balloon, and you can go maximum to expand to 4.2, 4.5. But that particular time we were having a 3.5 millimeter balloon. That too, it was very difficult to go through 18G needle. So we decided we'll inflate beyond the recommended burst pressure. We went up to 20, 22, thinking that we can achieve at least 3.5 millimeter. But at 3.5 itself, a balloon got ruptured. So therefore, we had to use 16 gauge needle and 4.5 millimeter balloon to open the valve. So otherwise, restenosis is common. Second question is mentioned, what is the time you do it? Generally, it is 26 to 27 weeks ideal. Sometimes we may do 25 weeks, 28 weeks also we have done, but more than that, two ethical questions will come. If you do at 30 weeks or 32 weeks, you can as well deliver the baby and do the procedure, number one. Number two, if you do the procedure lesser than 25 weeks, restenosis is very common. So you may have to do again in close to 50% of the cases. So that's why ideal timing is 26 to 28 weeks is probably ideal to do these procedures.
Okay. How do you counsel these patients, sir? What percentage of success rate and what percentage of failure rate or the negative percentages, what you give to the patient?
I think that's a wonderful thing. The three aspects of counseling we always emphasize. Number one, we may or may not do the procedure, because several times we admit the fetal position will not be great. You have anterior placenta and the fetal position is, you are considering borderline position, you have to go through the placenta several times. It's not a good idea to go through that. So when you have especially anterior placenta and fetal position is unfavorable, and your procedure itself, you may not attempt the procedure at all. So they have to wait for 3 to 5 days. Most of the patients, they may not like that. So admitted patients going for the procedure is only around 80%. Second is successfulness of the procedure. What is the successfulness of the procedure? Touch wood, we have so far only one death happened. That too, it was a fetal pulmonary valvulotomy in a critical, in a pulmonary artery syntax septum with a hydrops vitalis. We are writing that paper also. So it is learning curve. We crossed the learning curve at this point of time, because after 20-25 cases, we crossed the learning curve. But whenever is going to tell that, in the beginning you have to tell 30 to 40% a failure rate will be there. That means you can enter the uterus, baby thorax, but your needle, LV apex, aortic wall, coaxialing will not be there. All should be in one axis. Like planets are in one line. Jupiter, Saturn, all this, Venus, everything in one line will come. That's a very rare celestial event. So similarly, in the fetus, needle going and facing the aortic wall, you have to wait. So we adopted different method now. So the method is, we keep in the observation room. We don't keep in the operation theater and all. Observation room, morning will not be given anything. Start at 7 o'clock in the morning. See every 15 minutes. If the position is good, just give maternal anesthesia. Earlier we were giving a fetal anesthesia first. When you give fetal anesthesia, fetus used to move. Or when you ship the mother to theater, baby again moves. So that's why patient will be in the observation room. Once you get the good the coaxialing of the fetal left ventricular apex towards the anterior, then you give maternal anesthesia, then you do the procedure. With that, the success rate is going to be very high. The third part is the procedure and the post-natal procedures. If you have left ventricular mitral valve G scores are very low, foramina ovale is closed in utero, even though you do the balloon valvulotomy, your postnatal pulmonary hypertension is going to be there for longer time. So these three aspects we tell them, and we'll give the video. We'll first ask them to go through that literature, come back again next day, and then we'll counsel it. So I think close to 10% of people, they come. But nowadays SHWETA did not show some of the fetal intraperitoneal gamma globulin in maternal SLE patients. They all 100% they want actually. Probably that is because the previous abortions and the fetal bad obstetric history made them to go for the procedure. Maybe whenever we get a chance, we would like to present the series of fetal endocardial fibroelastosis with ventricular dysfunction and heart block. We give fetal intraperitoneal gamma globulin. So I think it is the reproducibility and standalone procedure. If you say multiple procedures after birth, generally they don't agree. If you say it is single procedure, most of the people, they agree.
Yes, endomyocardial fibrosis is a contraindication for doing the procedure, sir. And
not necessarily. Endomyocardial fibroelastosis with the left ventricular width and length are small, or mitral valve G scores more than -3, that means -3.2, -3. Those are the patients, even you do the procedure, they generally develop the restrictive physiology or hypoplastic left heart syndrome. Endomyocardial fibroelastosis grade 1 and 2 are not contraindicated.
Dr. Selvarani has asked any experience of an arrhythmia as a complication due to dilatation of chambers.
Shweta, you want to answer that?
Fetal bradycardia is very common, and almost 30 to 40% of them will develop fetal bradycardia. Therefore, we should be ready with intracardiac adrenaline and atropine. One of our case developed ventricular tachycardia, one case, and where there was inadequate opening of the aortic valve. So fetal bradycardia is very commonly seen after the procedure.
Fetal bradycardia is a transient common phenomena immediately followed by the procedure due to pericardial effusion. The pericardial effusion, if you wait for 2-3 minutes, generally you don't need to do. But if there is a persistent bradycardia, you have to aspirate or give atropine. We routinely, if there is a persistent bradycardia, we give intracardiac adrenaline and atropine. If the persistent bradycardia with a significant effusion, we aspirate that. So those procedures are simple. I don't think it's a very complicated. But of all fetal cardiac interventions, fetal pulmonary valvotomy is quite challenging and difficult because you have to go from the outflow rather than at the RV apex.
Somebody has asked, why choose maternal general anesthesia, sir? Can't it be done under local anesthesia?
Yeah, there's a university, Pittsburgh University, they do the procedure in the OPD basis, fetal anesthesia and then do. So originally our protocol was to give the fetal anesthesia, then give maternal sedation, and we were doing. Actually, while doing fetal anesthesia or shifting the patient to the theater, babies are getting moved. We are losing the positions. Now, worldwide people, including the Tuljar group from Austria, Boston Hospital, they all do maternal general anesthesia that goes to the fetus and you will have both stability. But our protocol is we give maternal general anesthesia and also top up fetal anesthesia we give. So, I think maternal general anesthesia is good for the fetal immobility and have the position for the procedure rather than any other thing.
I think there are no more questions, sir. It was an excellent presentation on fetal intervention, cardiac intervention, sir. We had a real treat today on a very, very delicate fetal procedure. We had an opportunity to watch it. Actually, I am watching it for the second time, and probably many of the observers would have watched it for the first time. So there are a lot of applauses and a lot of thumbs up for you, sir. Thank you very much for accepting our invitation. And on behalf of the Society of Fetal Medicine, Tamil Nadu chapter, we thank profusely both the moderators and the speakers for their contribution. And we look forward to have more lectures from you and participation from you. Thank you very much.
Thank you.
Thank you,
Have a
sir.
great weekend, all of you. Thank you.
Happy weekend.
Thank you. Thank you, sir.
Thank you, sir.